You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is September 26, 2025. Our topic is Evaluation of Recurrent Infections, presented by Dr. Nikita Raje. She is an Associate Professor of Internal Medicine, Pediatrics, and is the Chief in the Section of Allergy and Immunology at Children's Mercy Hospital.
Today's topic is evaluation of recurrent infections, and we're going to focus mainly on the inborn errors of immunity. I'm Nikita Raje from Children's Mercy Kansas City University, and today is September 26, 2025. I have to say that because I get a slap on my wrist every time I forget to say my name and the date. So here we go. Let's get started. And there you go. So those are my disclosures, nothing relevant to the talk today. Here are the objectives for the talk. To recognize the various causes of recurrent infections, to classify the primary immunodeficiencies or IEIs, and to outline the tests for various types of immunodeficiencies. So overall, the outline is in general laid out in a way that you would think. So why is it important to work up these patients with recurrent infections, and what kind of infections should we be worried about? What kind of diseases should we be thinking of, and why are we so worried about inborn errors of immunity? So we'll go over all of those, then finally delve into how to evaluate them and the different kinds of IEIs, and we'll go into the cases, and hopefully this gets to be more interactive. So why is it important to work up these patients with recurrent infections? So as you can imagine, that would help us reduce morbidity and mortality. Prevention is better than cure, so we would save some resources. And then the underlying cause, if known, would also have some implications apart from the recurrent infections, so that you could anticipate those and work towards getting those other issues better as well. What kind of infections should we be worried about? So any recurrent infections that can, those are more than the usual that you would expect for that age and scenario. Severe or life-threatening infections in unusual sites. So even a single infection, even if not recurrent, even if single infection in a sterile organ, say brain or liver, those are supposed to be sterile organs and not supposed to be to get infected as easily. So if you see an abscess in the liver, think of immunodeficiency, for example. Infections that are resistant to optimal therapy. So what do I mean by that? If there are sinus infections, you would expect those patients to have oral antibiotics and then get better. So you give those and then the infection doesn't get better, needs another round of oral antibiotics and then another and maybe IV antibiotics. That's kind of unusual, and you would start thinking of immunodeficiency again. Opportunistic infections, anytime you see those, you would think of inborn errors of immunity as well. So now that we know that recurrent infections are a problem, what kind of diseases should we be thinking of? So the topic for today is inborn errors of immunity. So clearly we will be thinking of those, but think about what's more common. So secondary immunodeficiencies are way more common compared to the primary immunodeficiencies or IEIs. And then there are some other causes that are even way more frequent or common than the causes of immune defect. So thinking about those other causes, you would think of the triad of the pathogen, host, and the environment, and the various factors that could be relevant to causing frequent infections. So that could be just the exposure. So a 2 or 3-year-old in daycare, or a younger toddler who's not going to daycare, but the siblings are school going, and they bring in that exposure. The sibling has grown up a little bit, so likely the immune system is a little more mature, but when they bring those viruses home, the toddler who is not yet as exposed to those microbes are likely going to get more sick, and it looks like the infections are more than usual, and there are concerns about whether this would be an immune issue. A lot of times that's all it is. As they grow up, the infections get better. There are other considerations such as smoking, acid reflux, having allergies. So allergies and nasal polyps leading to recurrent sinus infections, or having asthma and bronchiectasis. And sometimes it's hard to differentiate between two, and sometimes gets labeled as recurrent pneumonia. Atopic dermatitis with the skin affected. That's a risk factor for having recurrent MRSA infections, for example. Having cystic fibrosis or primary ciliary dyskinesia. These are more so structural issues that can lead to recurrent sinopulmonary infections. So all these causes of recurrent infections could be things that could lead to lots of infections being seen, but they have nothing to do with an abnormal immune system. Then there are these secondary immunodeficiencies. Here, the defect lies somewhere else, but the immune system gets affected because of that a secondary factor. So that could be an infection such as HIV. There are other viruses like EBV, CMV that can cause suppression of the immune system. Nutritional defects such as protein calorie malnutrition. Thankfully, we don't see that in this part of the world as much, but zinc deficiency is something that you may come across. Medications, so corticosteroids, chemotherapeutic agents, biological agents, radiation, even simple medicines like antiepileptics can cause low immunoglobulins and can look like an inborn error of immunity. Asplenia, that could be from trauma, it could be congenital and can cause immunodeficiency. The one from trauma is more secondary. Some congenital asplenia can be part of IEI. Extremes of age can also lead to either immaturity or senility of the immune system, and that can give rise to frequent infections. Protein losing conditions, so enteropathy or nephropathy, can cause loss of proteins. Along with those proteins are immunoglobulins that can be lost, and that can give rise to immune defects. And then some disorders like cancer and autoimmunity can also suppress the immune system. So those are all the different kinds of secondary immunodeficiency, and the list can go on. But the rare form, so those are the zebras, right? And we work in the space where we are always thinking of zebras, where these are more rare conditions. However, the defect is in the immune system itself. So let's think of the immune system. We know that the immune system is made up of different cells of the immune system that come from the bone marrow. And this is something very basic. We'll just fly through these stem cells can become lymphoid cells or myeloid cells, and have the choice of becoming different kinds of granulocytes or different types of lymphocytes. Apart from these cells, there are parts of the immune system that are labeled as either innate immunity or adaptive immune system. Adaptive immune system is more related to either the B cells or T cells, whereas the innate immune system is made up of whole different types of parts, including the first line of defense, which is provided by skin or epithelial layer, cells such as phagocytes, dendritic cells, and NK cells, proteins such as complements or toll-like receptors. The big difference between these two is the innate immunity is ready to go and functions right after the infection starts, versus the adaptive immunity takes days to weeks to get active. All right, so let's think about this scenario. Give me 1 second here. All right, so think about a child walking barefoot in the yard and getting a splinter in the toe. In that case, the first line of defense is already broken, so the splinter is in the tissue, and likely that splinter is sitting in that area for a while, and likely has a virus or a bacteria or a fungus sitting on it. So now that microbe has entered, the invader is inside the tissue. So thankfully, there are these sentinel cells such as macrophages, dendritic cells, mast cells that are present in the tissue, and they are ready to fight that infection. The macrophages releases some messenger molecules called cytokines that go to the site of infection, go to the circulation and inform the cells in the blood vessel that there is an infection going on. So the first responders from the blood circulation are the neutrophils that go to the site of infection to help out. Similarly, another sentinel cell in the tissue, dendritic cells, these are messenger cells. They take the information about what kind of infection is it and where is the infection. And they go into the lymphatic vessels and reach the lymph node. In the lymph node are our B and T cells. Once the message reaches the T and B cells, they start making their plan, and over a period of days to weeks, the T cells make helper T cells or killer T cells depending on the infection and help out with clearing that infection. The B cells differentiate into plasma cells, go to the bone marrow, start making immunoglobulin M, and over time switch to G, A, or E depending on the type of infection. And the overall result is that the infection is curtailed, and typically you may see the signs of inflammation at that site with swelling and redness and pain, but these patients typically don't end up in the ICU thanks to the innate immune system and adaptive immune system that take care of the infection right away. All right, so that's the working immune system. Let's think about the next question. Why are we worried about IEIs? So this graph is from 2024 International Union of Immunological Societies classification, and it shows how the number of immunodeficiencies have gone up over the years since the first immunodeficiency was discovered in the 80s. So at this point, there are about 508 different genes that cause IEIs, and these are the 10 different categories that we know that these immunodeficiencies fall into. And this classification is updated every couple of years. The classification from 2024 just came out this year, and this chart here shows that there were several of these immunodeficiencies that got added. So there were 67 different monogenic defects, and 2 phenocopies is what they are called, got added to the ones that were already known in 2022. All right. So how common are these IEIs? So we know these are rare disorders, but the initial, just a rough estimate of the incidence of IEIs was taken from a phone survey done by researchers, where someone called up the population and asked if they have immunodeficiency. And 1 in 1,200 replied that they had immune defect. We know that these immunodeficiencies can be as common as 1 in 300 to 400 for something like selective IgA deficiency, but most of them are pretty rare, such as severe combined immunodeficiency. Based on the newborn screening program, the estimated incidence is supposed to be 1 in 58,000, 1 in 250,000 for chronic granulomatous disease, and so on and so forth. So pretty rare disorders, but we know that some of the newer defects are extremely rare. At this point, there might be 1 or 2 cases known in the world for those rare disorders, and so the exact incidence is not known. So how do we evaluate these recurrent infections? So most commonly, we think that the important part of the evaluation is, as this slide suggests, is the history taking. But in practice, we know that everyone comes in with a list, right? They all come in with these recurrent infections. And so when do you know which patients to focus on? And so this is a list given by Jeffrey Modell Foundation. It's a foundation for immunodeficiencies, and it shows the 10 warning signs of when to think of immunodeficiency. So, as the list suggests, frequent infections, failure to gain weight, recurrent deep-seated infections or abscesses, opportunistic infections, including, for example, thrush or other fungal infection, need for IV antibiotics, deep-seated infections, and one of the important warning sign is family history of immunodeficiency. So any of these or a combination of these warning signs that you come across, always think of IEIs. So what kind of infection? So you really want to get the history of what kind of type of infection that you're seeing. And why does it matter? Because some of the immunodeficiencies are more prone for having particular types of infections. For example, if you see Serratia or Burkholderia, Staphylococcus, Candida, nocardia, some of these infections are known to occur in chronic granulomatous disease, or toll-like receptor TLR3 pathway defects are known to cause HSV encephalitis. So anytime you see HSV encephalitis, yes, you would think of T cells or NK cells to be part of, something that you would evaluate for, but TLR3 pathway should be in that differential as well. Enteroviral encephalitis has been known to occur in XLA. EBV is very interesting because one, there are several immunodeficiencies that are known to be associated with EBV. So these immunodeficiencies mentioned here increase the risk of having EBV, but EBV on the other hand can also suppress the immune system and cause problems. So it's regardless of which comes first, these patients can have immunosuppression or immunodeficiency. HPV infections are known to occur in DOCK8 deficiency, EVER1, EVER2, GATA2 deficiency, WHIM syndrome. Chronic mucocutaneous candidiasis can occur in multiple of these IEIs, including APOC3, IL-17 receptor defects, STAT1 gain of function. Invasive fungal infections, one known IEI is CARD9 defect. And then with SARS-CoV-2 infection, we know that there were several immunodeficiencies that were discovered in those patients with severe form of SARS-CoV-2 that occurred. So that 2 to 3% of the severe life-threatening SARS-CoV-2 or COVID occurred in patients with TLR3, UNC93B, some of the interferon alpha defects. So multiple of these are mentioned here. So again, the history about the type of infection is important because it guides you in what kind of IEI to think about. Besides infection, you really also want to get history about any other non-infectious issues. As this slide suggests, these patients can have a combination of autoimmunity or granulomas, lymphoproliferation that could be going on, combination of malignancy and infections, or atopy and infections can be signs of immunodeficiency. So let's think about some of these non-infectious issues and how some of those can go along with particular immunodeficiencies. So a common variable immunodeficiency is known to be associated with this presentation called GL-ILD. So it's a granulomatous lung disease that can occur in immunodeficiency. Apart from CVID, it has now been reported in several different types of immunodeficiencies, for example, 22q deletion or other forms of antibody or combined immunodeficiency. But the prominent feature of this GL-ILD is that if you have BAL on these patients and get a CD4-CD8 ratio, the ratio is different from what you would find in sarcoidosis, right, where you would also see granulomas. ALPS, autoimmune lymphoproliferative syndrome, you would see hepatosplenomegaly and lymphadenopathy along with cytopenias. 22q deletion syndrome, you may see autoimmune thrombocytopenia. Other cytopenias, you may see JIA. So again, lots of different immunodeficiencies can be associated with autoimmune features. Immune dysregulation, so you may see lymphoproliferation. So X-linked lymphoproliferative disease can be associated with EBV infections. As we talked about it earlier, malignancies are seen in some of these immunodeficiencies, and maybe particular type of malignancies may be seen with some particular IEIs. So selective IgA deficiencies, CVID, XLP are known to be associated with malignancies and multiple other ones. Atopy is seen in particular immunodeficiencies such as STAT3 and DOCK8 deficiency. So hyper IgE syndrome is what they are called. So STAT3 loss of function or Job syndrome is associated with cold abscesses and is associated with a lot of eczema and allergic issues. DOCK8 is a little different, a lot of viral susceptibility. So a lot of viral infections, HSV, HPV infections, along with significant atopy, so food allergies, seasonal allergies, eczema that is really hard to control. Viscott-Aldrich syndrome, those patients can present with eczematous rash as well. You will see high IgE along with that disorder as well. So that's, to sum it up, you are talking about getting history about infections along with the non-infectious issues, including malignancies, lymphoproliferation, autoimmunity. So history can give you a lot of information that comes in handy. Physical exams sometimes can be helpful, sometimes not really revealing. You may see some dysmorphic features, particularly for the syndromes that you may come across. There might be failure to thrive, hepatosplenomegaly, lymphadenopathy. There might be rashes that might come in handy for diagnosis. The features of particular syndromes, such as skeletal features in hyper IgE syndrome or cleft lip palate in 22q deletion. And sometimes absence of sign is a sign. So absence of tonsils in a young child, male child, or absence of lymph nodes, think about maybe XLA or SCID. So physical exam can give you some clues. Another clue here, ectodermal dysplasia. You'll see conical teeth, sparse hair, nails can be affected, skin can be affected. So so that's another feature that can be very prominent on physical exam. But a lot of the immune evaluation, your suspicion starts with the history, but then you need your lab evaluation to get to the diagnosis. So depending on your concern and types of infections or other features, you may be thinking of humoral immune defect or cellular immune defect, and based on that, some of the testing can differ. So the screening test for your humoral immune system is immunoglobulin levels, looking at specific antibody titers, so looking at vaccine responses. You can give booster vaccines and then reevaluate the response 4 to 6 weeks later. More testing in terms of advanced testing for humoral immunodeficiency includes flow cytometry to look for the B cell subsets, looking for advanced functional flow cytometry. So that looks for protein expression in some of the cells, such as you can look for the BTK protein or expression in monocytes to evaluate for X-linked agammaglobulinemia. So that's the typical testing that you'll perform for humoral immune system. Don't forget the genetic testing that comes in handy for all the categories. Cellular immune defects, your screening test is just a CBC with differential, looking for absolute lymphocyte count. ALC will be low if you're thinking of T cell quantitative defects. Flow cytometry again can be used to look for T, B, and NK cells and the subsets of T cells. And then Previously we used to use this cutaneous delayed type hypersensitivity test. We would use the candida antigen to perform the delayed hypersensitivity testing. That's almost like a TB test, but instead of the TB antigen, we would use the candida antigen. And if there is a response, you would think there is a CD4 function to be able to have that response to the candida antigen. And then the important screening test for T cells is your TREC screening, newborn screening for SCID that has been employed now in all 50 states. Advanced testing for cellular immunity includes microarray, looking for copy number variants for disorders such as 22q deletion. Similar features can be noted in 10p deletion as well. There are mitogen antigen assays that we can use for immune function testing. Again, the advanced flow cytometry can be used for looking for protein expression, such as in XLP, you may want to look for the expression of proteins such as SAP and XIAP. And then again, genetic testing is really important to get to the final diagnosis, and it goes in hand with the phenotypic testing as well. All right, what happens if you're thinking of phagocytic defects? Testing includes, of course, quantitative and qualitative evaluation. Your CBC-DIF gives you an ANC that gives you the quantitative information. For the function, you would do your oxidative burst test or dihydrorhodamine test. The older version of that was nitro-blue tetrazolium test, no longer performed, at least in this part of the world. There are other special tests such as flow cytometry for leukocyte adhesion defect that can be done, looking for CD18 or CD15A markers, and then genetic testing to look at the particular gene defect. So here is a picture of the DHR. How is this done? You take the blood sample, isolate the neutrophils, and they are tagged with something called dihydrorhodamine. Dihydrorhodamine, if it is oxidized, it gets converted to rhodamine, which is fluorescent. It emits that fluorescence, and then you can see in this chart how that fluorescence can be measured, and these are the histograms showing the fluorescence. So if those dihydrorhodamine tagged neutrophils are stimulated, they are stimulated by something called PMA, and once they are stimulated, if the neutrophils have oxidative capacity, then they can oxidize the dihydrorhodamine to rhodamine, and the fluorescence causes a shift in the graph. So this is a normal person where there is shift in the graph, so there is oxidative capacity of neutrophils. Here in panel B, you see there is no shifting of the graph, which means there is no fluorescence, which means there is no oxidative capacity for the dihydrorhodamine to be converted to rhodamine. And then in some patients, or you may see two subtypes of neutrophils, some with good oxidative capacity and some others not. And so you may see that picture as well. All right, testing for complement defects, you can go ahead and do your screening test, which is with CH50, AH50, and MBL. Now, I will tell you MBL pathway screening is not the best test because a lot of people are walking around, and not patients, I mean people who are healthy and may be walking around with low MBL level and may not have as much of clinical significance. CH50, H50 are used for the classical and alternative pathway screening, and if they are defective, you can move on to looking or testing for individual complement components. Innate immune evaluation. So depending on the suspicion for what kind of innate immune defect are you thinking of, there are toll-like receptor assays. These toll-like receptor assays are available for 1 to 11 TLRs, except for TLR3. There was an assay that was there for TLR3 that is no longer available. NK cell cytotoxicity assay, this is performed in various ways in different centers. There is a this particular marker, CD107A or LAMP, that can be tested, which can be a marker for NK cell cytotoxicity and is a reliable test. Your flow cytometry will also give you the quantitative information for NK cells, and then genetic testing might be something that you may have to look for just because of the limitations of testing for innate immune system. And then apart from all those immune tests that are available, always think of the secondary immune defects. So think about testing for HIV, EBV, CMV, inflammatory markers, and then anything that's going on. So biopsy of the affected tissue might come in handy. Peripheral smears can always be helpful in some of the patients. So that's what I wanted to talk about in terms of evaluation, except for the genetic testing. So before I move on to talking about genetic testing, I just wanted to stop here and see if there are any questions.
You mentioned 2 phenocopies that were added. Could you elaborate a little more on that and kind of what that means clinically?
Yeah. So that's a great question. And as I mentioned earlier, and I feel like there's so much information that sometimes I say things in a very specific way because there are always exceptions, as you have noted in this last year about immunology. So most of the primary immunodeficiencies are genetic. And the reason I say most is because most of the known gene defects, these 508 genes, cause various types of immunodeficiencies. But there are some, say CVID, for example, several patients, only 30% of CVID, there is a known genetic cause that we can find. But then there are all these patients where maybe it is genetic, but we don't know the cause, correct? On the other hand, there is a category called phenocopies of immunodeficiencies, which means that there is no germline gene defect in those patients, but they develop autoantibodies and they present like a genetic immunodeficiency. To give you an example, you see an older patient that looks like CGD, has abscesses, you feel like you're confident this is CGD, you get the testing comes back negative, right? The patient's getting a lot of recurrent skin infections, MRSA infections, and you can't figure out what it is. You may always want to think about, is there an autoantibody that developed for, say, IL-6 that caused a similar picture? So autoantibodies are acquired, right? They are not genetic, but then that causes a picture that looks exactly like another immunodeficiency. So that's called phenocopy. So same thing, not just the autoantibodies, there is another type of phenocopy, which is somatic mutations. So we know that ALPS is caused by defect in a gene called FAS. But there are patients who have features that look like autoimmune lymphoproliferative syndrome, ALPS, but when you look for the genetic test in your blood, you will not see the gene defect. But if you sort the T cells, the double negative T cells will have the gene defect. So it's a somatic gene defect that's not going to be passed on, right, in the next generation. So those somatic defects are also called phenocopies. So they look exactly like your ALPS, but they are not genetic, like germline genetic in origin. So those are called phenocopies. So coming back to the 2 defects, so those are the 2 novel defects that got added to the table 10, right? Table 10 is your phenocopies category of immunodeficiencies. And so that's what it refers to. And there are a couple of new ones that got added. And I just gave you a couple of examples, but there is a list. Yeah. So I typically don't go into the details of that just because, there's so much to talk about for the other 7-8 categories that we always discuss. So, but good question. Anything else? Okay, well, 30 slides done, just 54 more to go. So let's move on, talk about genetic testing. So why get genetic testing? So this figure shows that over time, we know that we now know 508 and maybe 5,000 more to go, right? That will be discovered. But at least we know 508 genes at this point that can cause IEIs. So a little bit of background about genetic material that gets tested. So our cell has nucleus that has the chromosomes, and the chromosomes have the DNA in them that's arranged, right? That DNA gets transcribed to RNA, and that gets translated to the protein. So that's just the basic part of that. But the genetic testing that we are looking for looks at various aspects of this genes to see where we find the defect. So I consider the testing for genetics and give the analogy of a library. So this is a library of genetic testing. Before we go on to talk about why it's the library, let's talk about the type of test, right? Well, let me go ahead and talk to you about the first type. So the karyotype, right? That's like the basic test for looking at genetic information. And if you are in a library and and you are in charge of finding anomalies or defects in the library, there are several ways of doing it. You can go, and if it's a very well-organized library, you can kind of have a look from further apart and look at the serial numbers of the books and see if there is something missing, right? If a book is missing. To look for that information, you have to move further away from the aisle and just look for the serial numbers and see if something is missing. That's what karyotype is. When you are looking from further away and seeing if there is a missing chromosome or a duplicated chromosome, such as a trisomy or a monosomy of any chromosomes, that's what the karyotype is doing. The next one is microarray. So instead of looking for a missing book, if you are looking for a missing page of a book, you would have to go further, closer to the shelf, pick up a book and flip through the book to look for that missing page. And microarray does that for the genes. So basically what it's doing is it's going through each of these parts of the genes to see if there is a missing piece of any kind of gene or the chromosome, and that information is given by a microarray. But then if you are looking at a missing word or misspelt word, then you are looking for sequencing testing, which means you open the book and you are going from one alphabet to another or one word to another and making sure that they are all there and there is no missing word or no missing letter, or if the letters are in the same place. And so it's almost like a spell check. And that spell check is done by sequencing. And there are different types of sequencing. So the simplest form is your single gene sequencing, such as if you're very sure that the disease you are looking at has one gene that is the most common cause of that disease, then you may want to get single gene sequencing. So the example for that is XLA. You see a patient with antibody deficiency, you are concerned that this is XLA, you may want to send for gene sequencing for BTK. And you may get your answer most of the times because that's the most common cause. Same way with microarray, if you are thinking this patient has typical features of 22q deletion, rather than doing sequencing, you may want to do a microarray. Panel of sequencing. So when you have a disease where you know a certain number of genes that can cause that defect, such as SCID, you may want to send a panel of gene sequencing. And then the more wider sequencing types are exome versus genome sequencing. And so exome sequencing is what clinically most of the times that's what you would start with if you want an expanded testing, because it looks for all the genes that code for proteins, right? So there are introns between the exons, and the exons come together and create the RNA that gets translated to protein. All protein coding genes can be sequenced when you are asking for exome sequencing. but the intronic genes will be maybe missed on exome sequencing. So if you want all of that included, that's your genome sequencing that includes all protein coding genes and the non-coding genes. And so if you typically would either start with the exome or one of the other testing above, but there might be a few places where genome sequencing might come in handy, especially with IEIs, maybe an undiagnosed IEI where you didn't find an answer with any of the other options. But there are times when you don't have that time. So someone who is critically ill, there are studies or centers who can perform, including ours, who can perform genome sequencing directly. Now, if you think about it, the exome, as this picture shows, is just the 1% of the overall genome, right? So a little slice of apple from the whole apple that you are looking for. So then why go for exome sequencing when you can get genome sequencing? And the big reason is that most of the disease-causing genes are in this 1% exome, 1% of those sequences. So it makes sense to start with the exome unless there is a reason to go for genome. And as we learn better technology for interpretation of genome, it might be a better choice, but at this point, we understand and can interpret exome way better than some of the complicated genomic sequences. Although there are some genes that cause immunodeficiency that will be missed on exome. So keeping that in mind, one example of that is cartilage hair hypoplasia, which is caused by an intronic gene. So in case you come across a patient where you're suspecting cartilage hair hypoplasia, exome sequencing may not be the best choice. More advanced sequencing, RNA sequencing, that looks for one further step apart from the DNA sequencing. And then there are different types of sequencing available at this point called long read sequencing that may give you more information. So just kind of keeping that in mind. So the idea behind talking about this library of genes, genetic tests, is that each test has its own value. And if you get, say, exome, and you realize that you are still missing something, you may have to keep in mind getting a more elaborate test doesn't mean you have looked at everything, which means that you may have got an exome, but if it did not include copy number of variants, you may miss 22q deletion because you are closer to that book in the library. You are opening up the book and looking for you are doing a spell check on each word and each letter. But you may miss a completely missing page because you're not looking for that. So keeping that in mind, or miss like a part of the chromosome that's missing. So just FYI, more elaborate testing does not mean that it's better. It just depends on what your suspicion is when you employ what kind of test you employ. All right, so moving on to our next question. What kind of IEIs are we thinking of, right? So you have a patient with recurrent infections, you have all this testing available, but what kind of testing do you think about? And, again, going back to all those different types of immunodeficiency. So here we come along and talk about the various cases. So now I can have you guys answer some of these questions for me. A 6-year-old boy was noted to have recurrent sinus infections, including one that needed IV antibiotic, had 3 episodes of pneumonia, frequent ear infections despite ear tubes, had gastroenteritis. He has no chronic medical conditions. What do you want to know about in the history for this patient? What labs would you get? And any IEI that fits this picture. So there's no, it's not a single answer. It can be multiple things that could be going on. That could be possible differential for this patient.
Family history, if we had any cultures that grew from the pneumonia, or blood cultures, or atypical pathogens. I'd be concerned about hypogam or CVID for this patient, what medications they're on, and I'll let other people do the rest.
All right, that's good. So if I tell you uncle, maternal uncle also had a similar picture, What would you think of?
XLA.
Yeah. Okay. Yeah. So the family history comes in handy. What kind of bugs those are? So all important information. So what kind of labs do you want to get? Anyone?
BBC diff, probably immunoglobulins, probably flow cytometry and complement.
Okay, yeah, that's a good start. So kind of, you get the gist. This is a patient with sinopulmonary infections, some GI infections. You may be, one of the suspicion is B cell defect, antibody defect. And if you think of antibody defects, these could be in various types, AGAM, CVID, functional or specific antibody deficiency, selective IgA deficiency. And these are the patients where you see sinopulmonary infections, GI infections. So thinking about those disorders, AGAM here, the B cells are, mature B cells are completely absent from circulation. So there are no immunoglobulins, and because of that, no good, the response to vaccines is either missing or not optimal. The most common cause of that is X-linked, caused by BTK, also known as Bruton's agammaglobulinemia. But then there are some autosomal recessive forms of agammaglobulinemia, which are less common, such as mu heavy chain, lambda 5, IgA alpha beta, blink, PIK defects. So the list goes on. The important part of that is to remember that there is these patients present after the maternal immunoglobulin disappears from the circulation at 3 to 6 months age, and then there are these patients will present with bacterial, viral infections, and then treatment is with replacement of immunoglobulins. Compared to AGAM, common variable immunodeficiency presents about after 4-year age. So that has to change 4-year age. And here the B cells may be normal in number, may be a little lower, but mature B cells will be present in circulation. Immunoglobulins may run low, and because of that, or completely absent, and then the response to vaccines is affected. So for common variable immunodeficiency is defined by having low IgG along with at least one of the IgM, IgA being low, and poor response to vaccines. Age more than 4-year age, and these findings not explained by another disorder. Right, like for example, SCID. They'll meet all the criteria for CVID, but you don't want to call them CVID because they have a severe defect that causes the SCID. Causes of common variable immunodeficiency, a lot of these disorders don't have a known gene defect, but there are several genes that have been associated and are commonly found in some of our patients here. Again, these patients present with infections, but as the name suggests, apart from infections, these patients can present with non-infectious issues, so variable presentation with autoimmunity, malignancies, granulomatous disease. Treatment is with immunoglobulins and may need immunosuppression or biologics for complications. Selective IgA deficiency, here the B cells are normal, your IgG-M are normal, it's just the IgA that is less than, is undetectable, or less than 7 is how it's defined, and they have to be more than 4-year age to meet these criteria. They can have low vaccine titers, sometimes response is normal, so these patients can be completely asymptomatic, walking around not knowing that they have an immunodeficiency. Some of them can have frequent infections, can develop autoimmunity as well. Some patients can evolve into a full-blown CVID over a period of time. Treatment depends on presentation. You can continue to just watch them. You can give them preventive antibiotics. Very rarely, they may need immunoglobulin replacement. Specific antibody deficiency, here the B cells are normal, your immunoglobulin levels are also normal. It's just the vaccine response that's low. This can be part of another immunodeficiency. Treatment depends again on presentation, monitoring, giving vaccine boosters, prophylactic antibiotics, and if that does not help, you may consider immunoglobulin replacement. Another condition is transient hypogam of infancy. Here, this is the reverse. Here, the B cells are normal for both transient hypogam as well as specific antibody deficiency. Here, this is the reverse of specific antibody deficiency. Immunoglobulins are low, but the specific antibodies are normal. This occurs because once the maternal immunoglobulins disappears at 3 to 6 months age in a baby, the baby's immune system may be lagging in making the antibodies, and that can continue up to 2 to 5 year age. Some of these patients can be asymptomatic, may just need monitoring. Some of them may need antibiotic prophylaxis or immunoglobulin replacement. Another case, 5-month-old infant is sent in for immunoevaluation for frequent infections and poor growth. He has frequent thrush, he has chronic runny nose and congestion and ear infections. What do you want to know? What labs would you want? And name some IEIs. Any other information that you need? Pretty broad, right? So let me give you some information. This patient, and I'm going to make this 2 scenarios, having eczematous rash and has low platelets. What are we thinking? Anyone?
Maybe Wiskott-Aldrich syndrome.
Okay, well, I'm going to change the scenario. Maybe this patient, mom says a child had a hole in the heart and then had some speech delay and is having all these infections. That's low calcium, hole in the heart, speech delay. George, so 22q deletion. Yeah, so so the same presentation can occur with a lot of different kind of combined immunodeficiencies. Here the T cells are affected, so the innate immune response initially may be normal, but when the message reaches the lymph nodes, the T cells may not do their job. And so in those cases, you may see SCID or combined immunodeficiency, immune dysregulation. Thinking about SCID, these patients present pretty early in life, have infections, rashes, recurrent diarrhea, failure to thrive, and treatment is stem cell transplant. These are just the subtypes of SCID. You look for the T, B, and NK phenotype, and there are various causes depending on that phenotype. We talked about newborn screening for SCID. This looks for this marker called T cell receptor excision circle that is used in PCR assay in every newborn. If it's normal, no further actions needed. If it's abnormal, you would have to do flow cytometry to look for the T cells. Here, the part of the DNA segment that makes the T cell receptor, part of it is cut and then rest is kind of joined together. So it leaves this part that is cut out to make a circle, and that's called T cell receptors excision circle. And the PCR assay looks for those tracks. If the T cells are normally developed and normal in number, you would have multiple tracks so that the newborn screen would be normal. If you have a defective newborn screen, abnormal newborn screen, you are thinking of SCID. If there are T cells that are less than 300 CD3 positive cells, if they are more than that, up to 1500, you may think of leaky SCID. If they have other features like erythroderma and hepatosplenomegaly, you are thinking of Omen's syndrome. And then there are other causes like secondary disorders or syndromes or prematurity that can also cause low TREX. And then there are times when you see low T cells, but there is no known cause, and that's called idiopathic T cell lymphopenia. That's a long list of combined immunodeficiencies that are not SCID. I'm not going to go into these details, but these patients can present with a lot of different type of recurrent infections. Another one is hyper IgM syndrome. Here, the T and B cells are normal in number, but they cannot communicate with each other, because of which B cells make IgM but cannot make G, A, or E. So they have, those numbers are low, and they can have recurrent bacterial infections, opportunistic infections. The main defect, the typical defect, is in CD40 ligand and CD40 that causes hyper IgM, but there are other causes, as mentioned here, that cause hyper IgM syndrome. All right. See, these are the subtypes of immunodeficiencies with syndromes. Again, hyper IgE syndrome or ataxia telangiectasia. Each of these have various features, syndromic features that are mentioned here. And we did talk about it with physical exam a little bit. We talked about Wiskott-Aldrich, small platelets, eczema, and recurrent infections. The defect is in a gene called WASP gene, and treatment is stem cell transplant. We talked about 22q deletion, heart defects, hypocalcemia. Less than 1% have thymic absence, which is congenital athymia. Those patients need thymic implant, but otherwise they just need supportive therapy with maybe immunoglobulin or prophylaxis, or they may just need monitoring. Hyper IgE syndrome, this is the typical facies. With asymmetry, broad nose, deep set eyes, and prominent forehead. That's Job syndrome. There are other causes of hyper IgE syndrome as noted here, and that those can be associated with infections and atopy. All right, 2-year-old with a perianal abscess that grew, Burkholderia cepacia. In the interest of time, as you may have guessed, we are talking about neutrophils. Neutrophils are our first responders that go to the site of infection. If they are defective, you see a lot of skin and subcutaneous infections, gingivitis, pneumonia, osteomyelitis. There are various defects. One of them is leukocyte adhesion defect, where they cannot apply the brakes that cause the infections to continue to occur for the skin and subcutaneous tissue. They are different types, LAD type 1, 2, and 3. LAD type 1 is the one that you think about with CD18 defect with delayed separation of umbilical cord. There's no pus formation and they have high neutrophil counts. Leukocyte adhesion type 2 and type 3 are less common, but they are milder forms and they may just need supportive treatment. LAD type 1 needs stem cell transplant. Chronic granulomatous disease is caused by defect in NADPH oxidase. This is the enzyme that gives rise to reaction to oxygen species, hydrogen peroxide, and bleach that kill the microbe after phagocytosis. If there is a defect in any of these components, that causes CGD, where there are infections with catalase positive organisms. And we looked at the dihydroamine rhodamine test, and then treatment is with stem cell transplant. You can give them supportive or prophylactic therapy with interferon gamma, antibacterial, and antifungal triple prophylaxis. 5-year-old who has vomiting and was diagnosed with meningitis, with H flu. You're typically looking for complement defect, and early complement defect cause cyanopulmonary infections and autoimmunity, and late complement defect cause encapsulated organism infections. All right, 10-month-old who has HSV meningoencephalitis. I did mention to you that these are patients with a TLR3 pathway defects, but there are multiple innate immune defects that present with particular infections, such as mycobacterial disease for MSMD, warts caused in patients with WHIM or EVER1, EVER2 defects, viral susceptibility in multiple of these, chronic mucocutaneous candidiasis present in, again, variety of disorders, and invasive fungal infections. And then the last category that I wanted to talk about is really rare disorders with these pattern recognition receptors. And one of the particular one is the TLR3 pathway defect with HSV encephalitis. Pyogenic infections and sepsis can be present in IRAK4 and MyD88. And there is NEMO defect that presents with ectodermal dysplasia and mycobacterial infections. Here's another one, 12-year-old with hearing loss and lymphedema and atypical mycobacterial lymphadenopathy. Here, NK cell defect can be a possibility with GATA2 defect that presents with hearing problems and lymphedema. These patients are susceptible to severe infections with EBV and herpes infections. All right, and then this one is a case of 10-year-old girl with recurrent thrush and candidiasis, vitiligo, low calcium, and this is along with adrenal insufficiency. So this is immune dysregulation disorder called APISED, but there are multiple categories of the immune dysregulation disorders such as familial HLH, Treg defects such as IPEX, APISED, autoimmunity with or without immune dysregulation, very early onset IBD, ALPS, we talked about that, and we talked about EBV. So various types of immune dysregulatory disorders. So again, just to sum it up, these are patients coming in with recurrent infections, but there are multiple other presentations and features that can lead you to think of different immunodeficiencies. So I'm going to stop here and see if you guys have any questions.